So for those I haven't met yet, my name is Brian Hurley. I work as the Director of Addiction Medicine for the Los Angeles County Department of Health Services. I'm also a volunteer assistant clinical professor at UCLA. And we're going to spend about 50 minutes, because I think altogether we have, another almost exactly 50 minutes to talk about medications for smoking cessation. All right. I don't have any conflicts of interest to disclose, so I don't get paid by anybody that's going to try to sell you anything. I don't have any pharmaceutical stock. I'm not in speakers bureaus. And this is the smoking cycle. The smoking cycle is people smoke. Smoking is the fastest way to introduce a drug to the brain. Nicotine goes to the brain quickly, usually within about 70 seconds after each puff. People feel relaxed. Nicotine binds to acetylcholine receptors in the brain called nicotinic acetylcholine receptors. And people feel an intoxication effect. And for people that become accustomed to it, they describe it as feeling relaxed and good. But nicotine levels fall quickly. And when nicotine, it's metabolized out of your system, usually in a matter of a few hours. And when the nicotine levels develop a tobacco use disorder, that is a regular sort of habit of nicotine intoxication. This is a simplified version of that same intoxication cycle. And it's really on cravings and helping diminish the intoxication effects of use that the medications that we have seem to work to help interrupt this cycle of tobacco use disorder. Prescribers that prescribe, or providers that prescribe medications for smoking cessation, really do have an opportunity to act. At this point, most people with tobacco use disorder would like to quit, right? Most people that use tobacco are not enthusiastic about their tobacco usage. But without assistance, it takes time to quit. And one of the reasons it takes time to quit is tobacco weaves itself into our lives in a way that's somewhat insidious. Most people that use tobacco regularly wake up in nicotine withdrawal, because if you spend the day with a nicotine blood level, overnight the nicotine level drops. Virtually everybody wakes up with the nicotine level of 0. So when your nicotine level is 0, when you're used to smoking more, right, you wake up and you have a cigarette. And then maybe you have a shower and you might have a cup of coffee. Coffee is a very commonly used intoxicant here in the United States, caffeine. So you have a coffee, and what goes with coffee is a cigarette. And then maybe you go about your day. Some people work, some people don't work, but you go about your day. You do whatever you're going to do. And on your way to go do whatever you're going to do, you have a cigarette. And then maybe you take a break from work. And a lot of people during their breaks they're called smoke breaks, right? You take a break and you go and you smoke. And then if something good happens at work, you celebrate with a cigarette. If something bad happens, you go lament that with a cigarette. You finish, whatever you're doing that day, whether it's work or otherwise, and you usually wrap up with a cigarette. And then on your way home, you go have a cigarette, and then you have dinner with a cigarette, you have lunch, you have a cigarette, you eat meals with a cigarette, right? Now, so quitting smoking, it sounds so easy, just don't smoke. But in reality, what you're asking somebody to do is to learn how to wake up and not have a cigarette. And then separately, how to learn how to drink coffee and not have a cigarette. And then separately, learn how to get to wherever they're going without having cigarettes. And how to learn taking breaks without having cigarettes. Learn how to eat meals without cigarettes. How to tolerate good things happening without smoking. Learn to tolerate bad things happening without smoking. To be able to get to and from and be able to have dinner without smoking. To be able to go to sleep without smoking. And so somebody might figure out a way to wake up and not smoke, right? Maybe wake up and have a nicotine patch, or put a nicotine lozenge or gum in their mouth. But that may not work for the coffee, right? You may need a different strategy for that. And so the quit rates tend to be relatively low per attempt. And what tends to be most successful is people that don't quit quitting. That is, you quit and then you try quitting again and you try quitting again. It's this persistence with quitting that gets people to transition from like a daily tobacco product user to not. And there are people who what's called cold turkey, they just stop. Right? They have one cigarette, they go through nicotine withdrawal, and they just stop. But there's no evidence that that works any better or worse than people that do more gradual quit attempts. And a lot of the people I work with are people that cut down. I used to smoke a pack, now I'm a half a pack. You smoke half a pack, now I'm at 10. Or 10 is half a pack. Now I'm at 5, now I'm at 3, right? Whittling down. But on its own, with any one quit attempt, the success rate is relatively low. And the medications actually can more than double the success of quit attempts. The classic algorithm for smoking cessation is called the 5 A's: ask, advise, assess, assist, arrange. The classic 5 A's are talking about quitting, right? Assess readiness to quit, assist in quitting. I actually have modified this slightly to incorporate change, right? Ask about tobacco use, advise to change tobacco use. Don't necessarily, I advise people to quit. It's not that I don't want people to quit. But if I say, are you ready to quit? And the person says no, I've suddenly obscured. I no longer know whether somebody is ready to cut down or not. They may not be ready to quit, but they might be ready to cut down. And if I use the word change, are you ready to change your tobacco product use as opposed to ready to quit? I open up the conversation to a broader range of things. And in fact, you can even use an amplified reflection to say, are you thinking about changing your smoking? If the patient says, what do you mean? What do you mean change? I might use an amplified reflection. Oh, well, you smoke a pack a day. Have you ever thought of going back to 2 packs a day, 3 packs a day, 4 packs a day? Try to hook up a carton of cigarettes to like a scuba diving outfit, so you're just inhaling cigarette smoke literally full time. And if I've done this correctly, they'll laugh. So they're no, no, that would be crazy. I can't afford that many cigarettes, and plus I know it would be bad for me, and I'd smell. And now I've gotten them to tell me why they don't want to smoke more. And it is way more valuable for me to understand the person's perspective, their ideas, their values, their intentions, their reasons why they don't want to smoke more. It's way better for me to know those than for me to be coming up with the reasons for somebody. Because people are so much better persuaded by the reasons that they come up with rather than anything I might come up with, right? Because for me, it's cancer, longevity, cardiovascular fitness, right? That's the stuff I might think of. For them, it might be cost, the staining of their teeth, and their smell, right? That might be the most important thing to them. And knowing what's most important for them is really important, because that's the key. That change talk, right? I see some people saying this is motivational interviewing. Exactly. So I advise to change tobacco use to meet somebody where they are, to really gauge their ideas and their intentions and their values before I begin to tell them, well, you can do this, you can do this, you can do that. I don't know how many, have any either witnessed a doctor or provider or been to a doctor or provider that didn't do that, right? Like, well, your blood pressure is up, so you got to do this, you got to do this, you got to do this. Meanwhile, never evaluating somebody's ideas or intentions or readiness to be able to do any of those things. And I think, last time I checked, it was, 50% of all prescriptions are taken as prescribed, which means 50% of all prescriptions are taken other than as prescribed. I mean, there's a lot of people that are not following through on the ideas that other people have for them. And the 5 A's can incorporate it, can include motivational interviewing, but the advise and the assessment of somebody's readiness and willingness to make a change attempt is really important. When you have an idea of what somebody's ready for, then assist in attempting to cut down or quit, and then arrange for follow-up. We tend to put smoking in an odd area of the medical chart. We tend to put smoking in the area of the medical chart for something called social history. Social history is, I would argue, not whether you smoke or not. Social history is where do you live, where you're from, what's your education, who's in your household, are you having any of the stressors, financial stressors, legal stressors. That to me is social history. I put smoking in medical history. Tobacco use disorder is a medical diagnosis, and we've got medical treatments to treat tobacco use disorder. And to make this point even further, people's smoke consumption affects their liver. In fact, it affects a liver enzyme called cytochrome P453A4. I think it's 1A2. 1A2, cyclophosphamide 1A2, which is responsible for metabolizing a whole bunch of the medications that we prescribe. Now, I'm a psychiatrist, so I prescribe a lot of antipsychotics, antidepressants, and anxiolytics. But in medicine, we prescribe all kinds of things. And in fact, if you go to this website from New South Wales, and I'll go ahead and put together a PDF of this and send it so that you guys can download it. But you can go to this link, or you can just literally Google like New South Wales medication interactions with smoking. There's a whole bunch of medications that are affected by our tobacco product usage, particularly, and it's not actually the nicotine, interestingly, it's the polycyclic aromatic hydrocarbons. It's the stuff in the smoke. It's the smoke itself that seems to cause an induction of liver enzymes that affect the metabolism of medications. And the clinical import of this is if somebody begins to change their smoking usage, the blood levels of their medications might go up or they might go down, right? And somebody who is, quote, stable on a set of meds might become unstable if suddenly their blood level changed, right? It became either at the toxic level or they changed their smoking. And psychiatrists in particular, and I say this as a psychiatrist, are particularly guilty of not documenting tobacco use disorder as a psychiatric diagnosis. Not treating tobacco use disorder. We tend to refer to quit lines of the, lower than other providers. Very few of our state psychiatric hospitals offer smoking cessation, and less than half of outpatient substance use disorder treatment providers offer smoking cessation or medication. So I think we may have folks from all over the country here. But for those of you in California, nobuts.org is our statewide quit line. You can usually find your quit line with a quick internet search, or you can go to smokefree.gov, which is a national website that links the state quit lines and a set of national resources. So now I'm going to pivot to talk just about them, not just, but I'm going to pivot to talk about the meds. There's really only 3 molecules that have been approved by the FDA to treat tobacco use disorder. One of them is nicotine, the other is Varenicline, the other is Bupropion. It's just 3. Now, nicotine comes in, thank you, Shannon. And yes, you're right, the polycyclic aromatic hydrocarbons are in any smoke. So you're smoking cannabis, anything that you're burning, then you're taking the smoke, is, you can get liver, cytochrome P450, 1A2, increased metabolism through that pathway. Okay, so it's nicotine, Varenicline, and Bupropion. Now, nicotine comes in 5 different formats, right? So there's 5 different formats of nicotine replacement therapy, and I'll just say countless different brands, right? There's a whole bunch of brands of the patch, of the gum, of the lozenge, but it's really only one molecule, which is nicotine. Comes in 5 different formats and a whole lot of different brands. Then there's Varenicline. It's a pill. It's still on patent, so there's only one version of it. And then there's Bupropion, which is generic, and it comes in 3 different durations. And I'll talk about each of these. We'll actually start with the nicotine replacement therapy. So this is the updated Surgeon General's report, and this is the pharmacologic product guide. Actually, the Surgeon General's report pulled this off of either the UCSF Smoking Cessation Leadership Program or off of WIP, which I think themselves got it off the Smoking Cessation Leadership Center, the SCLC at UCSF. But this is the table that covers the 5, each column is a different format of the medication. So gums, lozenges, patches, nasal sprays, and inhalers. And then there's the pills, Bupropion and Varenicline. I'm prescribing you a patch to quit smoking. Please wear it over your mouth. Well, okay, before I get into this, here's the table. Which of these medications is the most effective? Knowing nothing other than what we've talked about now, which of these medications is the best medication for smoking cessation? What do you think?
Gemtex.
So Varenicline. Thank you, Eden. We have one person that says Varenicline, and then Eden had a comment. Thank you, Jaylee. All right, so we have a lot of folks saying Varenicline. Thank you, Karim.
Nicotine patch.
Thank you, Mohammed.
What a bit.
Thank you, Sandra. Thank you, Bernardo. Thank you, Casey. Thank you, Kelly. Thank you, Anita. I'm sorry, there was Xenia. I think you were speaking.
Yeah, I said a combination of Varenicline and the patch and any.
Mm-hmm. Yeah, there was that JAMA trial, right, of Varenicline plus the patch. Thank you, Anya. Thank you, Lorraine. Thank you, Maria. Okay. So trick question, it's the one the patient takes. What's the best meds for smoking cessation? The one the patient takes. Doesn't matter if the clinical trials show that, Varenicline plus, nicotine replacement therapy is the strongest, because the truth is, if a patient doesn't take the medication, it doesn't matter. It's the one the patient takes. One the patient takes. Patient preference is absolutely by far and away the most important factor. It doesn't matter how strong, the effect size is if the patient doesn't take it. So that's the number 1, 2, 3, 4, and 5 most important things from my perspective is what is the patient ready for? I don't know your full name, G. Oliveri, but I will answer I will answer the SAPC question in a moment. I don't work for SAPC, so I'll tell you what I've heard, but I would also invite you to contact SAPC directly if you had a question about substance use or coverage. And just because it's a quick answer, the short answer is drug Medi-Cal absolutely does not cover smoking cessation. So drug Medi-Cal does not cover smoking cessation services. It is possible for a SAPC provider to order smoking cessation and for the patient to go pick it up, and it would be covered under someone's Medi-Cal benefit, the med costs, but SAPC won't reimburse the service, right, the provider's time, if the provider's time wasn't for a non-tobacco substance use disorder. So the short answer is drug Medi-Cal, which SAPC is the LA County funder that is the manager of the drug Medi-Cal here in LA County, if you live in LA. Drug Medi-Cal does not cover tobacco use disorder. And that is not set at SAPC. SAPC doesn't have the authority to use drug Medi-Cal to pay for smoking cessation. The authority is in Sacramento. So ultimately it's up to DHCS to decide what is covered and not covered under Medi-Cal. And drug Medi-Cal, tobacco use disorder is specifically excluded as an included diagnosis under drug Medi-Cal. Okay, so patient preference is the most important. Then, what you can get covered, that makes a big difference. If the patient can't get it, it doesn't matter whether or not they'd be willing to take it. Clinician familiarity with medications also oftentimes has a pretty big factor. Not every patient can take every medication. For example, there's some patients who have a predisposition to seizures. Bupropion is a medication that can trigger seizures. And so there are some patients where there's contraindication. If a patient has had a really good experience with the medication, that's important to remember so that you can restart that medication. If they've had a really terrible experience with a medication, that is also important, and you can steer clear and try not to reintroduce them to a medication they've had a terrible time with. And then patient characteristics. For example, bupropion is marketed both for smoking cessation and as an antidepressant. It's approved for depression. And not only is it an antidepressant, it can help mitigate weight gain. So it is, for those that can tolerate it, a reasonable option to consider adding for patients that are concerned about weight gain or have depression. So we'll start with nicotine replacement therapy. It comes in 7s, 14s, and 21s. I should update the slide. It does not come in 28s. So it's 7s, 14s, and 21s. And the way the patch works is you put it on hairless skin, and it slowly introduces nicotine into the bloodstream through the skin. It does not do that very quickly. In fact, it takes about 2 hours after you put on the patch before you're at what's called the steady state, or kind of the therapeutic blood level. There is no advantage to wearing the patch overnight. So the usual instructions are to put it on when waking and to take it off before going to sleep. Not every patient sleeps at night, so I don't say put on in the morning and take off at night. I just say put on when waking and take off before going to sleep, because there's no advantage to wearing it when somebody's asleep. It can sometimes cause skin irritation, and that is not from nicotine. Skin irritation comes from the adhesive. It's the sticky stuff that gets the patch to stick to the skin. So if somebody does have skin irritation, the recommended strategy is to switch brand. It's not that they can't take the patch. It's not that they're allergic to the patch. It's that they're not doing well with a particular brand of adhesive. And different brands use different adhesives, and the recommendation would be to switch to a different brand. Because the patch takes so long to kick in, it's recommended to combine it with gums, lozenges, inhalers, or nasal sprays. And either you keep those at your bedside, so people wake up in nicotine withdrawal. You can put on a patch, but you're not going to feel it for a while. So use the gum or lozenge or inhaler or nasal spray to create immediate relief of tobacco use disorder, and then put on a patch that would then create a steady blood level throughout the day to alleviate tobacco use disorder. The question was, from Sandra, was, would wearing the patch overnight help with early morning cravings? No, there's actually no evidence that it does that. So the evidence is that when you wear the patch overnight, it causes nightmares, but there's no difference in outcomes for people that wear the patch overnight versus not. So given that there's no advantage to wearing it overnight and some disadvantages with nightmares, the recommendation really is to take it off overnight. I understand, Sandra, the thought would be, if you wear it overnight, then you won't crave cigarettes in the morning. That's not true. People in the morning still crave cigarettes. Michelle asked me about the Eagle study. Yes, I can talk about the Eagle study. And Lilia says some brands are not covered by insurance. That's true. Although I will say I have found a phone call to a pharmacy can go a long way. If you're just using your electronic medical record to prescribe whatever, usually the pharmacy will default to whatever they have in stock. But if you explain to the pharmacist, this generic brand is causing a problem, the pharmacist can oftentimes research, are there any other generic brands that are in formulary? Or I've had pharmacists where you're like, look, you're prescribing a bunch of other, meds. We will throw in the cost of this because, it costs us $3, a month or something. I mean, I don't know exactly. Most NRT is more than $3 a month, but, the copay for an additional extra brand would be marginal. But the call to pharmacist can sometimes go a long way to help troubleshoot, specific brand, issues that somebody might be experiencing. So, and this is what's the right term? Foreshadowing for the future. The recommendation is not the patch alone. It's the patch plus a PRN, gum, lozenge, inhaler, or nasal spray, right? You combine combination NRT seems to be quite effective for those that take it. So have the as needed version, right? A gum, lozenge, inhaler, and nasal spray by the bedside for early awakenings. And if somebody's having a nicotine craving, they could take the inhaler, nasal spray, or gum or lozenge on top of the patch. The patch can come off easily with sweat or swimming, so you can use surgical tape to try to secure the patch to the skin, or to have an extra patch that you put on. Kareem says, can I provide you with evidence? Sure, I'll find a study and send it to you. If I don't get the study to you before the end of this conference, send me an email. Happy to send it to you. And combination NRT recommended over single formulation NRT. Gums and lozenges comes in 2s and 4s. The replacement boxes tend to be cheaper than starter kits. And the gum or lozenge, the way that they both work pretty much the same way. Nicotine absorbs through the cheek. You chew the gum, but you don't just sit there and chew it. You chew it and then you push against the cheek. It's called the chew and park method. Same with the lozenge. I had a patient chew the lozenge and swallow it, hoping that he would get the nicotine effect faster. And I was like, no, in fact, if you swallow nicotine, it's absorbed in your stomach without really being absorbed into your body. The lozenge, you wet it and you swirl against your cheek, and that's how you get the nicotine relief. With the gum, there's a peppery taste when there's nicotine on the outside. So you chew until there's a peppery taste, park it against your cheek. And then once the pepper taste goes away, the nicotine has been absorbed, so you chew it again to refresh the nicotine. And it's the chew and park is how nicotine gum works best. Lozenges, so there's inhalers and nasal sprays. They come in different strengths. I think inhalers comes in 4s and 10s, and nasal sprays come as 4s. There are some disadvantages to the nasal spray. It can cause nasal congestion, and the inhaler does sort of mimic smoking in a way that gums or lozenges don't. And they are anticipated to be covered under Medi-Cal, but they're not covered under Medi-Cal yet. Medi-Cal usually covers patches, gums, and lozenges. Where I work, our formulary is patches, gums, and lozenges. But you can get inhalers or nasal sprays, again, that you either fill out a TAR, so the Medi-Cal covers them outside of its formulary. But Medi-Cal is anticipated to cover these when the sort of pharmacy benefit switches over. There's going to be a centralized formulary within Medi-Cal. One other thing is the patches, the gums, and the lozenges are over the counter. So people can, if they have money, go purchase them. The inhalers and nasal sprays are only by prescription. Anita says, a huge percentage of people that smoke don't read the instructions, so may not use the gum part. Yeah, whenever I prescribe these, I actually, just as I'm doing during this presentation, I do the exact same thing. Make sure to park it. That's how you get the nicotine. It doesn't work if you chew it. You have to chew it and then park it. It's the parking that's important. I emphasize that to people because I can't tell you how many people, patch didn't work. I'm like, well, did you combine it with the gum or lozenge? They're like, oh, no. I'm like, gum or lozenge doesn't work. Well, did you actually use it as instructed? And most patients don't. I mean, not every patient, right? Some patients are very detailed. But some patients are like, hey, it's gum. I pop gum and, I'm not feeling anything. Well, if you're sitting there chewing your gum, you're not actually getting the nicotine into your bloodstream. Nicotine binds to receptors in the brain and a whole bunch of sites in the body. It has both stimulating properties and relaxing properties. This graph shows why we use combination NRT. The patch is the pink, and you'll notice that it takes 2 hours before you hit a peak effect. The dark blue is cigarettes. You get a peak effect very, very quickly. The nasal spray sort of mimics the slope of the amplitude of nicotine blood change with cigarettes. But with the nasal spray, you don't get quite the same amplitude. And the gum is even slower slope, but you do get, within half an hour, some peak effect with the gum that you don't get with the patch. So this is why if you're going to do nicotine replacement therapy, I can't remember the last time I just prescribed the patch. It's a patch plus, at least in my formulary, gum or lozenge. And if I worked outside, it would be gum, lozenge, and hazer or nasal spray. And how do I choose which one? The one the patient takes. Do you prefer the gum, the lozenge, the inhaler, or the nasal spray, right? And if somebody has questions about how they work, I'll go through them. But I don't pick for the patient. And if they're like, I'll go with whatever you recommend, and then it's based on whether they have teeth. So if they have teeth, gum. If no teeth, then lozenge. Let's see. So that's nicotine replacement therapy in a nutshell. Moving on to bupropion. So in bupropion is also an antidepressant under the trade name Wellbutrin is the trade name used for depression. Zyban is the trade name used for smoking cessation. It is the same molecule, right? Both are bupropion. Laura had a question about the nasal spray. The question was, is the nasal spray addictive? Nicotine is addictive. So any form of nicotine replacement therapy could, ostensibly cause a physiologic dependence and, potentially sort of addictive behavior. In fact, I have some patients that have been on patches, gums, and lozenges for many, they've stopped smoking, but they're on the patches, gums, and lozenges, and we're now trying to find ways to sort of get them off because they really experience strong cravings when they come off. Doesn't mean you can't use them. It's just, nicotine is an addictive chemical. Because the nasal spray sort of mimics smoking, it might be more addictive than the other forms of NRT. But that being said, they're all approved by the FDA, and it is way safer to be using a nasal spray, generally speaking. Assuming you don't have any particular otolaryngological issues or ear, nose, and throat problem, than it would be to continue smoking with all of that smoke and polycyclic aromatic hydrocarbon. Okay, so and then there was a question about my email address. So I will put in my email address if anybody has any questions. Okay, so it's bhurley@ucla.edu. So if any questions, please feel free to send me an email. Back to bupropion. So bupropion is also an antidepressant. It helps with depression. It can help with weight gain. Oh, Shanine, thank you for sharing your story. Bupropion is contraindicated. It's not recommended in those that have seizure disorders or with those with a predisposition to seizures. And if a patient has bipolar disorder, and I don't just mean like mood instability, I mean true diagnosed bipolar disorder, and they're not on a mood stabilizer, it's probably not a great medication for people with bipolar disorder because it can throw them into mania. I warn patients about jitters. It can cause anxiety, right? Bupropion is a very activating antidepressant. It can cause anxiety. It can cause insomnia if you take it too late in the day. I've had patients have a terrible dry mouth on bupropion. And there's people on bupropion lifelong, bupropion, many decades. You can safely combine it with nicotine replacement therapy. So for one option is the gum plus the lozenge, and you can actually add bupropion as well. And that might make sense if there's depression or if somebody's really concerned about weight gain and they're willing to take an extra pill. The XL version is thought to be just as effective as the SR version. The SR version is twice a day. XL is once a day. And usually for adherence reasons, a once-a-day version of bupropion is better adhered to than a twice-a-day version. And if you look at the blood level, you get roughly the same bang for the buck in terms of area under the curve of the XL version compared to the SR version. Interesting with bupropion, it's not the bupropion that seems to have the effect on smoking. It's a metabolite called hydroxybupropion, which is a major metabolite. 2D6 is responsible for converting bupropion to hydroxybupropion, and it's a non-competitive nicotine acetylcholine receptor antagonist. So it reduces the nicotine receptor's response to nicotine without blocking nicotine from binding to the receptor. There's all of these, this is, of all the meds, bupropion is the most sort of complicated because it's got the most contraindications and precautions. So you don't use it with other medications that lower seizure thresholds. There are dosing changes with people that have impaired liver metabolism. It's not recommended to start bupropion in a patient that's pregnant or breastfeeding, although you generally don't automatically stop it just because the patient is pregnant or breastfeeding. It's not FDA approved for adolescents. And there used to be a black box warning that was removed in 2016 about neuropsychiatric symptoms, particularly suicidal thoughts and psychosis and mania. These side effects are still present, but they're actually very, very rare. They very rarely result in suicide attempts or psychiatric hospitalizations. And the thought is the benefits of quitting smoking are substantial, and the risks of the medication are less substantial. The contraindications, again, you don't give it to patients that have a true seizure disorder. If somebody's already on Wellbutrin, you don't give them Zyban, right? If they're already on bupropion, you don't give them more bupropion. If they have current or prior diagnosis of bulimia or anorexia, which predisposes people to seizures. If somebody's going to stop drinking all of a sudden, that puts them at risk for seizures. So you generally don't, give bupropion to patients that are, at high risk for seizures. And you don't give it to patients who have what are called monoamine oxidase inhibitors prescribed to them. And Varenicline. So Varenicline is a what's called high affinity partial agonist at the alpha-4. I'm sorry, it just keeps advancing on its own. Is a partial agonist at the alpha-4 beta-2 nicotinic acetylcholine receptor. It mildly activates the receptor. You get a little bit of a nicotine effect when you take the medication, and it lasts roughly 12 hours, right? You get like a full nicotine effect when you take the medication. Or not full, sorry, a partial nicotine effect, but it lasts a long time, much longer than nicotine does. But it binds the receptor, gives a little bit of a nicotine effect, but blocks nicotine from binding, right? That's how it works. So you add Varenicline, gives you a little bit of a nicotine effect, but blocks nicotine from binding. What I've seen with my patients is they say smoking tastes different. So it tastes different when I smoke now. In fact, I had one patient, she went from smoking a pack a day to 3 cigarettes a day, 20 to 3, huge win. And she came back, she's like, I'm mad at you. I'm like, why am I mad? Why are you mad at me? She's like, well, the smoking doesn't taste that good anymore, but I'm still not quit. I was like, well, the meds will help you change your smoking, but you still have to quit. Like the meds won't make you quit. You still have to quit. And she's like, what? I was really hoping the med would do everything. The med would do the whole work. I'm like, no, usually with smoking cessation, there's medication strategies, but there's also behavioral strategies, and the combination of those things is what we recommend. Because Varenicline does cause a little bit of this nicotine effect, if somebody stops taking it all of a sudden, they can experience an increase in smoking cessation. And they can experience not increased smoke cessation, an increase in nicotine withdrawal and smoking craving. So Michelle asked, are there recommendations of weaning patients from bupropion? I'll tell you what the general rules of weaning people from bupropion. It depends on how long they've been on it. So if somebody's on bupropion for 2 weeks, you can usually get them off in 2 or 3 days. If they've been on 300 once a day for 2 weeks, usually do like 150 once a day for 3 days and then off. If they've been on bupropion for several months, right, 6 months, then maybe you give it about a month, right? Take them down to 150 for a couple weeks, 3-4 weeks, and then off. If they've been on bupropion for several years, well, then you might want to taper them down over the course of 2 or 3 months, just to make sure it doesn't cause any destabilization. Kind of similar with Varenicline, right? Varenicline is 0.5 milligram once a day for 3 days, 0.5 milligram twice a day for 4 days, and then 1 milligram twice a day thereafter. 1 milligram twice a day, which is 2 milligrams in total a day, is recommended. Xenia asks, can a low dose, 0.5 milligrams a day, work better for some patients with heavy titration? Only if they can't tolerate the full dose. All right, varenicline makes sense to get to the full dose if the patient can tolerate it. So I would only go down to the 0.5 milligram twice a day would be kind of the next level to go down. If they can't tolerate 1 milligram twice a day, 0.5 milligram twice a day would be the next level to go down if they can't tolerate the higher dose. But in the trials that were done, it was the 1 milligram twice a day dose that was tested. I think there was one trial on a 1 milligram once a day dose that had some reduced effects. So usually you try to get the person at the max dose so they can tolerate up to 1 milligram twice a day. The usual treatment course is anywhere between 3 months to 6 months, although there's some evidence of longer-term varenicline. And in general, you know, you treat somebody with medications for smoking cessation until they quit. And this is the thing that, you know, I think is sometimes overlooked, is people are like, well, I gave them a 3-week supply, they should quit already. I'm like, no, no, no. You start them on a medication, you see how they respond, and then you taper somebody off. You don't just give everybody a, you know, a 3-month taper or 6-month taper, or, you know, just, you know, you have to individualize the medication strategy, because some people are going to need much longer term treatment and some people are going to need less. And so we start meds, see how somebody responds, and then we taper off in an individualized manner. Okay. H. Vanstein says, recommended for clients that have had bariatric surgery, that have had, cannot drink the full glass of water, to take Chantix to prevent stomachache. Yes, you could. I will say I have not treated a lot of bariatric surgery clients right after surgery where you really have to worry about that. But I think that taking varenicline after food is likely to help prevent stomachache. And then Kareem says, what about the growing evidence of NRT safe in cardiovascular disease? Even if a patient will be having a cabbage, it's still recommended in the medication sheet as contraindication, like the countries I practice in. NRTs are only affordable for most smokers. Yes, I think that although a current MI or myocardial infarction, or somebody who's sort of pending cabbage or stenting, gosh, why am I catheterization, is still on the packaging with contraindicated. It is way better to give somebody the relief from the nicotine withdrawal than usually is the exposure. So generally, I do recommend, even if somebody is like, I had a patient in the ICU, right, on tele, you know, pending cath, it was on Integralin or something. And I recommended giving nicotine replacement therapy, because the worst thing that'll happen, right, is worsening myocardial infusion, right? The vasoconstriction from the nicotine is the big concern there. But they're on tele, right? Like if they do really get a change in perfusion that causes any dysrhythmia, you'll be able to pick it up relatively quickly. Deidre says, what's the reason for the titration? Tolerability, right? Nausea, insomnia, and headache are all tolerability issues with varenicline. It's my understanding in individuals with serious mental illness that varenicline may be needed for up to 1 year. I would say 1 year or even longer. I've had patients on varenicline for a very long time if they need it. Are there any studies on possible impact of smoking cessation meds or energy for patients on hormone replacement therapy? So there is some evidence that hormone replacement therapy is contraindicated in some smokers, but NRT, it's thought that they have to do with the coagulation state, right? People with tobacco use disorder can be in a hypercoagulable state, and you don't want people to have a stroke. But you can absolutely use NRT and smoking cessation meds on patients with hormone replacement therapy because they don't increase coagulation risk. For a patient with oral cavity or oropharynx cancer, okay to use the nicotine gauze or lum. Depends on how much. Yes, it is. It's not carcinogenic. The gum or lozenge doesn't cause cancer. It's the chew that's in the tobacco leaves or in other things like different kind of synthetic chews that are thought to be carcinogenic. So as long as somebody has a cheek and the ability to chew, then they can use the gum or lozenge. There's some indication that the nicotine replacement, the efficacy of some chemotherapy meds or cancer treatments. I would be interested in reading that literature. I don't work in a lot of oncology settings where I need to worry about nicotine and its effect on chemotherapy meds or cancer treatments. So Shannon, I appreciate your bringing that up. And if you have any recommended resources, I recommend you. I appreciate you sharing. So varenicline is one of the few medications that's not extensively metabolized. Most of us urinate out unconjugated varenicline. It is, so, it's not extensively metabolized in the liver. There's not a lot of dose adjustments and hepatic failure. But you do dose, there is a dose adjustment that is necessary in renal impairment, which would be a reason to go down to a lower dose. It's not recommended during pregnancy or breastfeeding. Its safety just hasn't been established. And it's not FDA approved for adolescents. There used to be a black box warning that said that varenicline can cause suicidal thoughts or mania or psychosis, but again, that warning was removed in 2016. Nausea, sleep disturbance, headache, farting, constipation, taste alteration, and rare neuropsychiatric symptoms are the major side effects. So there was a study came out in 2012 that said that there was a higher occurrence of cardiovascular events with varenicline as compared to placebo. Subsequent studies have essentially exonerated varenicline. There was not a statistically significant effect of varenicline compared to placebo on cardiovascular events. The benefits of reduced smoking on cardiovascular risks are substantial and immediate. Varenicline, again, there was a trend that was not statistically or clinically significant. And at this point, we don't think of varenicline as being associated with cardiovascular risk. But what about neuropsychiatric risks? Bernardo says, what would I recommend it for under 18? So for under 18, usually first line is behavioral treatments. If somebody's not responding to behavioral treatments, nicotine replacement therapy. Otherwise, off-label varenicline can be, you can use, off-label Bupropion you can use, and off-label varenicline. But just to be clear, it's off-label. It's not recommended or FDA approved. Bruce also recommends, what do you all there's some contingency rewards, right? If you smoke less, then you'll have more money as a contingency as a longer term for smoking cessation. Corolla asks, is there an overdose risk if people use NRT and continue smoking? There's a theoretical risk, but I'll say in practice, not really. And the reason I say in practice, not really, is if somebody's nicotine replacement therapy plus they're smoking on top of NRT gets their nicotine levels too high, they probably won't smoke more, because at that point they'll be nauseous and nicotine will become aversive when the dose gets too high. Now, I don't try to overdose anybody, but I encourage people to take NRT even if they continue to smoke, because most people, even if they're not intending to, smoke less when they take nicotine replacement therapy. One of the other questions was, what about off-label things like clonidine or nortriptyline? I've not found a lot of success in either. I have some other patients that I've used clonidine or nortriptyline in, and there's some off-label evidence, but again, I haven't been hugely impressed. But you can, right? It's possible to use them. Again, there's not strong evidence that they seem to have strong effects. Ultimately, the FDA rescinded the black box warning for neuropsychiatric effects, saying, it is true that the risk of neuropsychiatric effects due to varenicline or bupropion is present. It is lower than was previously suspected. And the risk of mental side effects is still present, particularly in those that have mental illnesses such as depression, anxiety, schizophrenia, or otherwise. But most of the people that have these side effects did not become psychiatrically hospitalized, did not attempt suicide. And the benefits of stopping smoking outweigh the risks of these medications. So what I tell my patients, and the first place I learned to use varenicline was at a clozapine clinic, a clinic for people with severe mental illness. And most of the patients did fine. So I just instruct patients, if this medication doesn't go well, right? If this medication goes poorly and you begin to experience suicidal thoughts or, depressive or mood symptoms or other kinds of mood symptoms, stop taking the medication and call me. If it emerges, it tends to emerge soon, within the first couple of weeks of taking it. It's not something that you have to worry about at month 2, 3, or 4. Carrie Montessa says, is there a maximum length of time to use NRT? No, there's no maximum. Sophia says, can patients get more addicted to nicotine with lozenge use? Not really. Smoking is incredibly addictive because of the route of administration. Lozenges, you can develop a physiologic dependence on lozenges, but it's much more rare. What's the benefits of NRT if using varenicline? In fact, there was a JAMA trial on this, looking at varenicline plus NRT. And interestingly, although varenicline seems to block nicotine receptors, adding nicotine, varenicline, still gets some breakthrough effects, and people still experiencing a reduction in cravings. So you can use varenicline and nicotine replacement therapy on top of varenicline. So in schizophrenia, in most stable, closely monitored patients with schizophrenia, varenicline treatment is now associated with worsening psychiatric symptoms and used monitor for an exacerbation of psychiatric symptoms. The slides also, there is clonidine and nortriptyline. They are second-line pharmacotherapies that you can use off-label. What I tend to do is, rather than like, okay, you tried the patch, that didn't work, so here's clonidine. It's, okay, we tried the patch, now let's try the patch plus the gummer lozenge. Okay, let's do the patch plus gummer lozenge plus bupropion, or varenicline plus the gummer lozenge plus bupropion. Like, I start to add combinations of the FDA-approved agents rather than going to the second-line agents. But if somebody really has blown through all three, nicotine, varenicline, and bupropion, and is still really looking for some help, well, then we do have clonidine and nortriptyline. So for pregnancy, psychosocial treatment, behavioral therapies are first line. If you're going to use a med, nicotine replacement therapy, the conventional wisdom is that the harms related to NRT use are limited, and that NRT is safer than smoking. So I'd rather use nicotine replacement therapy than the patient continuing to smoke. If you do use nicotine replacement therapy during pregnancy, realize that nicotine is metabolized faster during pregnancy, and the body volume goes up, so the dose needs to go up. There's not really sufficient data to support the use of varenicline and bupropion during pregnancy, but there are patients who, but there's no really known teratogenicity either. And kind of the same deal with breastfeeding, right? The use of NRT while breastfeeding is safer than continuing to smoke. There is some lactated nicotine, but most of that lactated milk goes into the stomach of the infant, and the stomach of the infant does not absorb nicotine, right? The nicotine is metabolized in the stomach without being absorbed. And so it is safer to breastfeed on NRT than to breastfeed while smoking. Bupropion is present in the breast milk of lactating women, and the last I checked, we don't know whether varenicline is secreted in human breast milk. So what do we know about the Eagles trial? So the Eagles trial says a lot of people need meds at higher doses for longer durations and in combination. The more psychological distress you have, the more psychosocial instability you have, oftentimes the more medication support you need. People with bipolar disorder should really only receive bupropion if they're on a mood stabilizer, and each agent can be used in people with schizophrenia or other forms of severe mental illness. Anya says, I recommend the patch for basal lozenge and the lozenge for breakthrough cravings. Anya, I think that's exactly right. That's exactly the strategy. We recommend that people quit smoking when they go to rehab. A lot of patients ignore us. And this is just a slide like quitting smoking during rehab, right? When people are encouraged, maybe 14% of people who have tobacco use sort of quit smoking during, say, addiction treatment, like non-tobacco addiction treatment, like alcohol or heroin, cocaine, other forms of substance use disorders. But 11% of non-smokers start, right? It's maddening that people go to addiction treatment, and going to addiction treatment is a risk factor for starting smoking. It's nuts. People who quit smoking in rehab are more likely to be in remission from their primary substance use. And this is just, it's a chart, it's a figure 1 from a VA handbook looking at the comparative efficacy of medications for smoking cessation. And you'll see varenicline of any single agent seems to have the strongest effect, and again, of those that take it. But the combination NRT, the patch plus the gummer lozenge, Anya, I think you mentioned that strategy. That makes a lot of sense, of the patch plus the gummer lozenge for breakthrough cravings. And that seems to have an even stronger effect than varenicline. But what's not in this handbook is varenicline plus nicotine replacement therapy, or varenicline plus nicotine replacement therapy plus bupropion, right? And this is what we've built where I work, is if somebody is a tobacco product user, but they don't use every day, if they say, I smoke when I go out, but I don't smoke every day, well, you can give them a gummer lozenge that they can take with them. And when they feel like smoking, when they have that urge, they use the gummer or the lozenge to help address that craving. If somebody's smoking 8 or fewer cigarettes a day, then starting with a 7 milligram patch is appropriate, plus a 2 milligram gummer lozenge plus bupropion. And, or instead of the patch, you can use varenicline, and there's some evidence of using varenicline plus the patch. And then as the number of cigarettes somebody smokes a day goes up, the strength of the patch goes up. So 9 to 15 cigarettes gets you a 14 milligram patch. And 16 plus cigarettes gets you a 21 milligram patch. Somebody smokes 2 packs of cigarettes a day, that's 20 cigarettes a day. 2 21 milligram patches is appropriate. Because if they're smoking that much a day, you know that they can physiologically tolerate that much nicotine. Do I recommend vaping or e-cigarettes? I don't. And in fact, I think there was a chat on here of, I use Varenicline and it works for smoking, but it's not working for vaping. Yeah, vaping is built to be quite addictive. The entire vaping industry is built to, yes, Jaylee, I will PDF this and I'll send you the handout. Vaping or e-cigarettes are built to keep you hooked on nicotine. The nicotine replacement therapy products are not. They're not nearly as rewarding. So I don't recommend vaping. There's this Lancet article, that e-cigarettes are associated with less quitting. So here's some resources, smokefree.gov. There's a 12-step group for smoking cessation called Nicotine Anonymous. A lot of this material is from the SCLC, Smoking Cessation Leadership Center at UCSF. And I don't recommend light cigarettes or natural cigarettes. Are not any safer. I don't recommend smokeless tobacco or snus. It's carcinogenic and just as addictive. I don't recommend e-cigarettes. And the key is to not quit quitting. It takes lots of attempts for people to quit. So don't quit quitting. It's persistence is key. I think I gave you a bhurley at ucla.edu email address. There's another email address you can use, but bhurley at ucla.edu is probably the best one to reach me on. Everyone stay logged in because we need to show you the CE code. So what's going to happen is this room is going to close in 1 minute. And then when we go back to the large group, you'll see the CE code. Do I recommend giving medications for e-cigarettes? Yes. And I recommend it in exactly the same way. I treat e-cigarette use like smoking. So I treat it in the exact same way. The difference is I know how much a pack of cigarettes is. I have to ask how much is, how much is the pods that you're buying. And, oh, thanks, Bruce. Let's see. And then do I recommend, thank you for the information. Yes, I will go ahead and circulate the, I'll go ahead and circulate the PDF. Okay. Thank you, everybody. And
yeah, everyone's coming back.
I am.
Okay, good. He can actually answer this question better than me. So the questions are, is the curriculum available and can they access it? So I was just saying that it was created for the DRP program that we have going in LA County, and it is currently being used by solely them. And the hope is that the curriculum will become available at some point, but when that is, I don't know, maybe Dr. Hurley can assist with that.
We are planning on publishing the manual once the study is complete. But to right now, because of the study design, not every site gets access to the curriculum, so we haven't published it more widely. So as soon as it's published, we're happy to update everybody at the conference so that you know. I wish I could give you a better answer, but yeah, we will publish it usually when the study's over. We think that's still a few years away, unfortunately.